This webinar has been created by Australian and New Zealander women with Asherman syndrome. Thank you to the Women's Health and Research Institute of Australia and the Australian Women's Health Alliance for their support throughout this project. Please note this webinar has been created with a budget of $0 and very limited technical expertise. Every single person who has participated did so in their own free time. Please be tolerant of any tech issues. We have all done our very best. All of the women took considerable time to get a diagnosis of Asherman syndrome. I'm going to ask women with Asherman's to share their experiences of this. But firstly, Professor Thierry Van Kai, can you tell us how Asherman syndrome is actually diagnosed?
The diagnosis of Asherman syndrome is made by direct observation, visual observation of the presence of scar tissue. Ultrasound can give you an indication that something's wrong, but in the end, there is a need for hysteroscopy to actually see the presence of scar tissue.
I want to hear from Laura and Naomi from Asherman's Australia and New Zealand. Is it common for women to struggle to get a diagnosis of Asherman syndrome? And what are some of the barriers to being diagnosed?
A major barrier for women in getting a diagnosis is that they have no idea about this condition or that they should even be seeking diagnosis for it. And often they find the same with their general practitioner. So they'll go to the GP with some vague symptoms that the GP might not put two and two together with Asherman's, or as Professor Van Kai has said to us, often women have no symptoms at all except unexplained infertility. So there's no one putting two and two together, ordering the right diagnosis test for them, or sometimes women are having a regular ultrasound because that's what is ordered for them by their doctor or specialist. And when that comes back as having no issues, they're all given a false sense of security that there's no issue because you need a specialised ultrasound called a saline sonography to get the diagnosis or a hysteroscopy. So they're some of the really common barriers. And then there's also the cost barriers to these investigations, which I know that you're going to talk about soon.
The first port of call in getting a diagnosis is often the GP. Dr. Jade Wally, I'm keen to hear from you what level of advice GPs often get from hospitals or obstetricians when a D&C has been performed. Are you advised to follow up on the risk of Asherman syndrome?
Sometimes it can be difficult to get instructions from the hospital and, if you don't receive discharge summaries. A lot of the time, particularly out in community, women will come see you and they don't really mention that they've had a procedure done, but they just say, they've been to the big hospital, and sometimes you have to chase reasons as to why that was. And I guess the bonus of having obstetric care and knowledge is that if knowing that a patient is requiring a D&C, that is part of the consent process in explaining that Asherman's is a risk, and trying to explain that in the most simplest terms as possible, as well as the other risks of D&Cs, can be quite difficult, particularly with certain health literacy rates, particularly of young girls who are needing them done. There is a high rate of surgical terminations, particularly in community as well as within Broome. And I think sometimes when there is that shame factor as well, that a lot of patients want to keep it under wraps, and if you aren't the GP that sees them on the day to get that organised, it's hard to know if it's happened, and if discharge summaries or documentation doesn't get faxed through to the AMS or out to the community clinics, then there's no knowledge of what has taken place. So that can be quite difficult. But I feel the longer you work, because it's such a transient town as well, the longer you work in community and get to know certain specialists, particularly with the benefit of knowing the obstetricians in Broome, it's a bit easier to communicate via email to know who needs chasing up and where to find patients. So, yeah.
It's worth me adding here that there are women living in cities with access to the best facilities who are undergoing round after round of failed fertility treatment without actually having their Asherman syndrome diagnosed. This scarring does not come up on regular transvaginal ultrasounds, so women and specialists alike can be totally oblivious unless the correct investigations are completed. So if a woman has significant scarring in her uterus, doing IVF treatment can be pointless unless that scarring is removed. How would your patients go with getting a diagnosis of Asherman syndrome? And are there any additional barriers for rural and regional patients seeking support from a GP when they have concerns about gynaecological conditions?
I guess adding on from what the previous question in terms of accessing diagnostic tests and treatment for Asherman syndrome, within Broome it is getting a bit easier in terms of access to the gynaecology team, and I guess we have 3 gynaecologists who triage referrals in order to get these things done. I guess the hardest thing can be actually getting patients to hospital, and if they are to have a hysteroscopy, making sure that they have the right phone number and transport and are aware as to why and what is happening. And I guess from a community point of view, being 2 hours away from Broome, a lot of the time patients don't have access to cars, so they do need to be booked into the clinic transport, the car. And if the car's full for the next 2 weeks, then it can be tricky to actually, particularly if they need ultrasounds or appointments with a gynaecologist, it can be difficult to coordinate to ensure that they make that and can coordinate management.
Are there any cultural barriers your female patients experience when seeking care for gynaecological conditions that might be causing them pain or fertility concerns?
I found the cultural barriers are mostly if there's no access to a female doctor. So in community at the moment, I do 4 weeks and then a male doctor does 4 weeks. And there are patients who aren't comfortable in seeing a male doctor, so they do wait until I'm back to be seen, or they head into town to get management at the hospital if it's if the pain is severe. In Broome, it's a bit different because at the AMS you can request a female doctor, which is better access for female patients. And then in terms of fertility, I have found that there is some shame in talking about that, and having tried with some patients for a few years with their partners, but not realising that there's a problem in that, and that's more so in with some of the community patients compared to my experience at Brahms. So I think I have found that there is a bit of delay in discussing that and feeling comfortable in bringing that up in a consult, and I have tried to make it part of my practice to ensure that, particularly with health checks with most female patients, to address that and any concerns that they might have, so that they actually have the opportunity to discuss that.
Dr. Kite, what differences have you noticed up in Broome in terms of diagnostic options for women compared to your previous work in Sydney?
So the difference between Broome and Sydney is access and the type of investigations that we're able to perform or have performed locally. We do have ultrasound. We have quite a good ultrasound unit here, but we don't have access to imaging techniques such as hycosi, where fluid's distilled into the uterine cavity that is often helpful for diagnosing intrauterine pathology. We have access to a CT scan, but no MRI locally. We can perform hysteroscopies. We have a theatre, and we can perform a number of procedures in our theatre locally. The closest tertiary centre to us is Darwin, but more commonly people would be referred to Perth for more advanced investigative options.
Professor Van Kai, do you think Asherman's is underdiagnosed?
There is no doubt that Asherman syndrome is underdiagnosed, and it will continue to be underdiagnosed, simply because more than 60% of women with Asherman syndrome have no symptom whatsoever. There's no change in menstrual pattern, there's no pain, there's no indication that something is wrong until they try to get pregnant.
Yes, I do think that Asherman's is underdiagnosed. I think both within general practice and sometimes even within specialist gynaecology services, it's not considered as a diagnosis and so can be missed.
So a woman finally gets the diagnosis of Asherman syndrome. I'm keen to know what that is like for a woman. Naomi and Laura, can you share experiences from the Asherman's community?
I think sometimes it can be a relief initially for women to get a diagnosis and to understand what's actually happening with their body, because often they've had this feeling that something's not right and maybe pushed to have it investigated. But then it can sometimes feel like quite a bleak diagnosis for women because they might be told by specialists that they might not be able to have a baby or that surrogacy is their only option, and women might be starting to run through their options in their head and thinking, oh my gosh, I can't afford this, I don't have any options to manage this. I think for women especially who haven't had any children at all, to get this diagnosis can be life-shattering and lead to many issues mentally and severe depression and all of that, which I know the mental health experts will speak about in this webinar. It can also make women feel very alone to get this diagnosis because it's not well known, and most of us had never heard of it before being diagnosed with it. So I think you can feel like you don't know anyone else who has it. And I definitely felt that way until I joined an online support group, and within half an hour I had connected with a friend that I went to high school with who actually had the condition, and I'd had no idea. It can feel like your friends and your family don't actually understand the condition because it's so rare, and for women that have maybe had a pregnancy in the past that people know about, they might say, well, you got pregnant before, it's all good, you'll get pregnant again, and they just don't understand that there's actually a difference now, which might make it very hard to become pregnant.
Yes, it's a huge burden on women who, when they get the diagnosis, are often in shock and they're devastated. Managing this assumes that women have the emotional capacity, the knowledge, the finances, the support, the awareness to make a good decision with, in needing information to be able to make that. The not knowing is reported to be terrifying. Women often report having felt desperate and having an extreme lack of trust after receiving this diagnosis. Women reported things like, "I've lost hope. I feel so much regret about the decisions I've made. These decisions were life-shattering. I was poked and prodded so much when they were trying to work out what was going on after having a procedure." Women said that it felt crazy that they were told it was a safe routine and less than 1% of women experienced infertility as a result. And then at the other end, being told when they were, coming and saying, "I've got a light period," that they were one of the lucky ones. Women reported feeling gaslit. Some women reported that when they were telling medical professionals about their symptoms, that they were told that this was their body's way of getting ready to get pregnant again. So yes, traumatized by the outcome and the struggle to go back and see a clinician due to the PTSD and extreme lack of trust that they have felt in terms of working again with the consultants and specialists that they've worked with.
Getting a diagnosis of Asherman syndrome is often not cheap. Women who suspect they have Asherman's and get a referral for a saline-infused sonohysterogram need to pay approximately $600 out of pocket as of January 2024. For some, this is simply not affordable. Some women opt to go straight for a hysteroscopy, generally privately due to the extensive public waitlists, therefore needing to be able to cover the cost of both private health insurance and any admission fees. And then women move on to the action phase of actually trying to get treatment for their Asherman's. Laura, Naomi, I'm keen to hear about this.
Getting surgery for Asherman's can be really triggering for women because it's actually a surgery that caused their problem in the first place, and then they're having to trust another surgery to fix the problem. So I know especially when you're going interstate for surgery away from all of your natural supports. I know when I had my surgery with Professor Van Kai in Sydney, I had to be pretty quickly sedated when I was at the hospital by his lovely anaesthetist because I just got so freaked out by the situation. And then there's also the financial toll of Asherman's, particularly for women that go on to do IVF, or for the women who do round after round of IVF without even being diagnosed with Asherman's. It's just a huge financial burden.
Professor Van Kai, why are women from all over Australia flying to Sydney to seek treatment? Can't they get it treated locally?
Women with Asherman syndrome have to travel sometimes long distance to get treated. And that's because very few colleagues have had the opportunity to acquire the necessary skill set to treat the condition.
Is it realistic for most women to fly to Sydney for treatment? What do our rural participants have to say about this?
No, flying to Sydney is not a realistic option for most of our patients. We do have support services to fly people generally to Perth if they require more advanced care or more care options than we're able to provide in Broome. However, that doesn't cover all costs, and so it may still be out of reach for many people. Additionally, accessing care in the private system, which is often more timely and flexible for treating something like Asherman's, is not within reach of many people within our population up here. So just some final thoughts on other differences between regional and cities. So I talked a little bit about diagnosing it, so we don't have access to hycosi in Broome. People have to travel to Perth or Darwin or another major city to access that investigation. We can diagnose on hysteroscopy, but treating it can be challenging in a regional centre. We don't have the same access to a large array of equipment in a small town like Broome as we do in a major tertiary hospital, and so that sometimes means referring people to their major city. They may have waited to see us, and then they'll go on a wait list to see someone at a major hospital in a city, and then they'll go on a wait list to have their surgery. All of this is more expensive for someone who lives in a regional area, even though they do have their subsidies, and it means a lot more time away from family, from other kids if they have them, from jobs, from other responsibilities. So being able to treat locally certainly can reduce a lot of those burdens for people.
We also have a woman, Leah, who is Asherman's and lives in regional Western Australia. Leah, tell us what it has been like for you.
Treatment-wise, I had options of travelling to Sydney or travelling to Perth, Sydney being the gold standard from Dr. Kite. Both options were extremely expensive. I would have been looking at about $12,000 to $15,000 just for myself, for airfares, accommodation, the procedure, time off work. This is without travelling with a support person, and this is leaving my family behind for I'm not even sure how long if I had to go over east, and how many procedures I would have needed. That also might have included multiple trips. I looked at accessing my super early. I looked at personal loans. At the end of the day, my husband and I, it's been almost a year since my diagnosis. We have decided for various reasons just to focus on the family that we have and not to pursue any further intervention.
Bonnie Corbin, you're the chair of the Australian Women's Health Alliance. Are these struggles experienced by rural women consistent with what you have heard?
People in regional and remote areas experience complex barriers in accessing women's healthcare, in particular Aboriginal and Torres Strait Islander women, migrant and refugee women, young and ageing women, and LGBTIQ people. Regional, rural, and remote Australia is at the pointy end of our global workforce shortage, where we have a lack of midwives, nurses, doctors, and other health professionals. This means that most procedures require travelling to a metropolitan area. Every week, we hear from women and their support people who travel hundreds of kilometres to access healthcare, which can involve long drives, boat travel, overnight accommodation, multiple flights, and delays. Travelling to access healthcare is not just about physical access to a service, but it's also about things like getting childcare, communicating with an employer about needing to take leave, having access to adequate personal leave for recovery, and the stress of navigating follow-up appointments or allied health access during recovery. While telehealth has long filled access gaps in regional, rural, and remote communities, it can't cover all areas of healthcare and is not a substitute for face-to-face care. Australia claims to have a universal access system to healthcare since 1984, but coverage is so far from universal. While some costs are covered under Medicare, women still face significant out-of-pocket costs when it comes to pregnancy-related care, particularly those living in rural, regional, and remote communities. It's also an issue for women on temporary.
From what everyone has shared, not least the women with Asherman's, it seems like a very inconvenient condition to have, hard to diagnose, hard to treat, so it does sound like avoiding it from occurring in the first place is a priority. Would you agree, Professor Van Kai?
I strongly agree that avoiding the occurrence of scar tissue within the uterine cavity is a priority. rather than improving treatment. Let's just start improving prevention.
I'm keen to hear from the experts about what is the best practice for D&Cs. Firstly, when they should be avoided in favour of conservative treatment options, and what are these conservative treatment options?
In the absence of heavy bleeding and potentially severe infection, a miscarriage should be treated by expected management. What does this mean? It means that we wait for about a week or so, and in many cases the uterus will expose to products of conception. If that's not the case after about a week, then we add medical management with products such as misoprostol. About half of the patients will actually avoid surgical management using that regime, especially if the miscarriage was their first pregnancy. The disadvantage of this conservative approach is that it takes longer, more than a week, usually. It will also have a greater impact psychologically on the patient, and in many cases it will come with some significant pain as the uterus contracts over a long period of time in an attempt to expose those products of conception. However, most women are willing to take on those disadvantages in order to avoid potentially a surgical intervention in half the cases.
This is question 5. So best practice, I think, has evolved since I began my training. Initially, we would perform the procedures blind, which means we would judge whether the cavity was empty by feel and clinical signs. And now more commonly, we perform the procedure with ultrasound guidance. That's certainly routine practice where I work now, here in Broome. And it's helpful to ensure that we're evacuating the cavity completely to the best of our ability, and to also ensure that we're not being overly zealous with our attempts to empty the cavity. The highest risk times for performing a D&C in terms of developing scarring within the uterus are in the postpartum, and that weeks 2 to 4 seem to be the most risky. We would try to avoid instrumenting the uterus in these times if possible. It's not always possible. However, treating more conservatively with antibiotics to reduce infection and bleeding, and then following up down the track with more imaging and following the patient's return of cycle can be more conservative options. We know that the greater the number of procedures that someone has, the higher the risk that they may develop Asherman's. Potentially talking to someone who has had a miscarriage or is looking for a termination of pregnancy about medical management is possibly a way to reduce the risk of developing Asherman's. And really importantly, making sure people are aware of their options for contraception to avoid unwanted pregnancies could certainly be helpful.
When a D&C must be done, what is best practice, including follow-up afterwards?
Knowing that the presence of retained products and the occurrence of infection were the two main triggers to cause intrauterine scarring, we need to make sure that the surgical intervention we perform does indeed remove all products of conception and prevents the occurrence of infection. Now, how do we do that? The most common way to actually visualize the uterus and the uterine content is ultrasound. So we need ultrasound guidance, and preventing infection can be done, or reducing the risk for infection can be done by using prophylactic antibiotics. follow-up after surgical intervention for removal of retained products is important. The patient should experience a return of menses within 6 weeks of the procedure, and a menstrual episode should be similar to what they were before. If there's any doubt about the return to normality, a referral for pelvic ultrasound should be organized.
Who do you think is responsible for promoting best practice guidelines for D&C's management of retained products of conception in Australia?
It is the responsibility of the college to define and promote best practice in the management of gynaecological conditions.
We have an obstetric sonographer with us today, Sarah Douthwaite, who is currently doing a PhD to explore the role of ultrasound guidance in reducing complications in gynaecological surgeries. Sarah, can you tell us more about this and about the role of ultrasound in reducing Asherman's and other complications?
Hello, my name is Sarah Douthwaite. I'm a research student at the University of Sydney. My thesis title is The Role of the Sonographer in Theatre Performing Ultrasound Guidance for Obstetric and Gynaecology Procedures, a mixed methods assessment for any gaps in service provision. Unfortunately, pregnancy loss can have the complications of retained products of conception or a retained placenta after birth. If these women have surgical management, there are potential complications: an inability to access the cavity, creation of a false passage, uterine perforation, incomplete evacuation of the cavity or continued retained products, the creation of adhesions or Asherman syndrome, and heavy blood loss. A seminal article by Dani about the use of ultrasound stated, "Intraoperative ultrasonography does not obviate the need for sensitive and careful manipulation of the intrauterine forceps, but it does increase the surgeon's ability to direct the forceps away from areas where perforation is a risk and towards the tissue to be evacuated. Ultrasound guidance can help prevent complications of D&Cs. With a full bladder, the precise size and axis of the uterus can be seen without the need for measuring by the uterine sound instrument pictured. This also helps with the entry angle for the uterus for instruments and could help prevent trauma to the cervix. Instruments can be guided into the uterus. Dilators, suction and forceps can be guided into the cavity. This can decrease false passages and decrease perforation. Instruments can also be under constant view. Just as we guide marinas in our outpatient setting, we can monitor the progress of instruments through the cervix for D&Cs. Instruments can also be guided to exactly where the retained products are located. Specifically, guidance could help prevent Asherman syndrome by confirming the completeness of the uterine evacuation, especially important for Müllerian changes in cavity shape. We can check in 2 planes that the entire cavity is empty, and this can decrease retained products of conception and help reduce repeated surgeries. Guidance can also reduce a final check curettage and instrument sweep by the surgeon to feel the cavity. Excessive curettage of the softened layers of the endometrium could be reduced, which could decrease hemorrhage and Asherman syndrome. I have just had ethics approval to look at the outcomes for sonographer ultrasound guidance of uterine curettage compared to the outcomes of blind evacuation for the removal of retained products of conception or incomplete miscarriages. This will be a 5-year retrospective cohort analysis, and I'm expecting this to show the benefits of ultrasound guidance in reducing complications. The goals of my research are to understand the role and use of ultrasound guidance in Australia, develop training guidelines for sonographers, and hopefully improve patient outcomes by assessing where the gaps in service provision are.
It's great to know what best practice is, but I'm also keen to understand how this might play out on the ground in areas without access to facilities such as rural settings. Dr. Lauren Kite, you're a gynaecologist who was trained by Professor Van Kai in Sydney, where you had access to all the best facilities, but you're currently doing a stint in Broome, northwest WA. So in rural areas, are there additional barriers to D&Cs being done according to best practice?
So for the most part, I think we do our best to perform D&Cs according to best practice here in Broome and in the Kimberley more broadly. I can't really speak for other areas where I haven't worked before. Primarily, we do this by performing all our procedures with ultrasound guidance, so having a second practitioner in the room scanning while the primary surgeon would perform the procedure. The bigger difference, I suppose, between working in a remote community compared to a big tertiary hospital or even a smaller hospital in a major city is our access to resources. So we have far more limitations in terms of access to blood products. While we have an operating theatre, it's not a 24-hour staffed operating theatre. Staff would have to come in from home. We have fewer practitioners and a smaller number of staff around to be able to manage an emergency. So that always will adjust the way that we manage people. We have to think about potential downsides to conservative management if it's not successful, and try to avoid situations that are going to be more than we're able to safely manage in a community like Broome. We also have to think about the fact that many of our patients, while they are treated in Broome, don't reside in Broome, and so they will return to a far more remote community where there are even fewer resources. Developing an infection there or bleeding heavily in such a remote community could be really disastrous, and obviously require their transfer back to us. For that reason, potentially people are more likely to end up with a procedure than they would otherwise. I don't have the stats to support that necessarily, but having conservative management often means a longer stay in Broome, which means being away from family and community for a longer time than if someone were to have a D&C for a miscarriage or a termination, for example.
Dr. Adrian Lower, do you have any thoughts to share with us on best practice for D&Cs?
There is in fact a nice guideline on the management of ectopic pregnancy and miscarriage, and I'll send a link to that guideline, which is available on the internet. That has been developed by members of the RCOG and patient representatives. And it still doesn't necessarily go far enough, but there's certainly a vogue in the UK at the moment to manage miscarriage conservatively where possible, then moving on to managing it medically, and then if all of that fails, then a D&C will be required. That's not always going to avoid Asherman's, and sometimes that might make it worse, because by waiting you may get an infection, and with an infection and then having to do a D&C, then you're going to get much worse adhesions and the endometrium becomes much more friable. So sometimes the manager would be better to do an initial D&C or ERPC or an MVA under ultrasound control where you're being fairly clear about taking the tissue away. But there's still a risk of Asherman syndrome, and it doesn't always... The development of Asherman syndrome doesn't always mean that the procedure has been done badly, and it's quite difficult to prove negligence on the basis of adhesions, that there was something done wrong. I think the best way of winning a case at the moment is through not being adequately informed and not having adequate consent. But there are times when the consent issue is overturned by the need to do something. For instance, if somebody has a severe infection, you can't always wait at that point. But each case has to be judged on its merits, and it's certainly far from clear.
It's time to talk about the elephant in the room, consent. When I've seen the ABC coverage about Asherman's and spoken to women who have the condition, this seems to be the issue that concerns them the most. Laura, Naomi, can you tell me women's experience of providing consent for a D&C?
I just want to be clear that we're not anti-D&C. We understand that a D&C is sometimes absolutely necessary, especially in an emergency situation. And there might also be times when a woman chooses this procedure over more conservative options despite the risks, because for them it feels like the most appropriate option. And we encourage that, we respect that. Women should make informed decisions about what's going to be best for them, given all the information to make that informed choice. It's also really crucial that women are given all of the information so that they can be aware of the signs to look out for of Asherman. So even if a woman has had a D&C in an emergency situation, they need to be told about the risk of Asherman's afterwards, once they're safe and recovered, so that they know the signs to look out for and also what to do if any of those signs develop, so that they can get diagnosed promptly, because that's something that we see as a real issue, that women aren't aware of the risk, therefore don't put two and two together when they get some of the symptoms, and then they don't get a diagnosis and just have unexplained infertility. Sadly, it's extremely rare for women to feel like they've given informed consent for a D&C procedure in relation to Asherman's and fertility. We'll now hear two women's experiences of consent with regards to their D&C, starting with Leah, and then we'll hear from Helen.
I didn't know any alternatives to a D&C. I was scared. My child was at home. I was a new mother. Just thought that's what was done. I didn't know. I still don't know if there are any options, which is why I feel so invested in this webinar and spreading the word for other women. There was no discussion about Asherman syndrome. I do not recall it ever being mentioned. I had never heard of it until my diagnosis. I'm a registered nurse. I know about informed consent, and despite being scared, nervous, in hospital for a procedure during COVID times, I definitely do not recall Asherman syndrome ever being mentioned in my consent.
No, I don't feel that I was adequately warned about the serious complications that could happen after a D&C. I was given the you could bleed, you could get an infection. That's all I was told. And when I went back and asked them why I was never told about Asherman's, I was told, well, when you have your tonsils out, you could die, but they don't tell you that because we don't tell you all the complications. It's up to you to research and work that out for yourself.
This was a consent form for a woman who had a D&C at 3 weeks postpartum. Case study Hayley, who had a life-threatening hemorrhage and developed Asherman syndrome. This form lists bleeding, infection, organ damage, DVT, PE. Hayley is adamant that there was no verbal discussion of risks, and her obstetrician strangely had no case notes whatsoever from the consult. Yet when Hayley tried to make a complaint, she was told, "You signed the consent form, you knew the risks." I'd love to hear what women with Asherman's have to say about this.
It's getting very old, you signed the consent form, you knew the risks line, which is the response that so many women do seem to get when they make a complaint or they're not happy when they've developed Asherman's. I feel like looking at this consent form, for example, you're not getting, so this is a woman that's had a D&C in the 2 to 4 weeks postpartum, which as we know placed her at a 25% risk of developing Asherman's. I'm certainly not getting that from this form, or the risk of associated infertility. You'd be relying on someone doing a lot of research to pull that information from this form. It's just not there. And then, you know, bleeding, what's bleeding? I feel like every single surgery you have, there'd be risk of bleeding, but I'm not getting risk of significant hemorrhage from this form, which, as it turns out, the woman was at high risk of experiencing. So risks need to be teased out in a way that actually makes sense to your average person.
Dr. Adrian Lower, you're an Asherman syndrome specialist and gynaecological surgeon in the United Kingdom. Do you think this consent form is adequate? What does informed consent look like? Do you think Australian women have valid concerns when they say they're not giving informed consent for this procedure?
I've been asked to comment on this consent form, which on the presentation I've got is slide 22. This consent form is typical of many which one sees, unfortunately, and 10 years ago it probably would have been considered acceptable, but now it's not. It lists the information which the patient has been told about and really represents just a summary of the exchange. And a doctor could argue that those are the headings on which he discussed and would rely on his normal practice to say this is what he normally talked to people about. But it doesn't really stand up in the current climate, and I think you need to be much more specific about the risks, the level of risk which is involved, and those risks need to be explained in simple terms that non-medical people can understand if they're to make a decision about a particular form of treatment. Can't change practice overnight, and a doctor should be judged against the standards that are in place at the time that the incident occurs. Things will probably change, and this practice would perhaps not be considered acceptable now or in the near future. The standards for consent, as we've discussed, are changing, and I think that your support group has gained significant traction in trying to increase awareness of Asherman syndrome amongst clinicians. Education and prevention of the condition where possible is rather more important than raging against a poor outcome now. However, I do think it's appropriate that women suffering with Asherman syndrome should receive financial help in dealing with the consequences, and I've been involved in a number of medical legal cases that have resulted in some compensation for individuals, but that doesn't really change the outcome and win back the time that they would have lost in trying to deal with this.
Martin McDougall, you've provided mental health support to multiple women affected by Asherman syndrome. What sort of headspace are women usually in when they're asked to sign consent forms like this?
In my experience, women relate feeling a false sense of security by the medical professionals that they worked with, trusting that they would give the best and most informed treatment options. And with hindsight, what they repeatedly related is that they had not been in an optimal place to really question the potential side effects of surgery, often due to being in a heightened emotional state, and often they've needed to make a rush decision because they were told that surgery was needed imminently. So not being given information about the risks of repeated D&Cs and fertility, so they often felt that they got lost in the system. This, of course, can lead to self-doubt and blame for not knowing more. But, of course, you need knowledge and awareness, and they weren't informed, so they couldn't make that informed consent. Women often stated, I knew something was wrong. And what is striking is that most women found out about Asherman's through their own quest to find the truth, through research and, asking questions. The realisation that I was misinformed and unaware of a significant life-changing risk is very overwhelming. That's what women have said to me. And a daunting realisation when it comes to then going on to manage the medical system.
These next two slides are copies of the consent form that I signed in the hospital that did my D&C. As you can see, there's warnings about bleeding, infection, tearing of the cervix or a perforated uterus. Nowhere in this consent form does it state anything about Asherman's or scarring of the uterus or anything to do with infertility for that matter. I would like to tell you that this consent form has been changed, as I did ask the hospital to do this in 2018. I have followed up with them on 3 occasions to find out if they did update this consent form, and I've not heard anything back. Last year we conducted a poll in our group about consent, and of the women that responded, 97% of them said that they did not give informed consent, meaning that they were not warned of the risks of Asherman syndrome, or they were given some information but it was so vague that it was not useful.
We've got some quotes here from some of the women who said that they were given some information about the risk but not enough, and it really goes to show that they were not giving informed consent at all.
The lack of informed consent is a serious issue, and sadly one that seems to happen all too often in women's healthcare. But let's talk to an expert. Bonnie Corbin, you're the chairperson of the Australian Women's Health Alliance. Do you see informed consent as being a significant issue in women's healthcare?
Everyone has the right to consent. It's the foundation of the Australian Charter of Healthcare Rights. Consent is a gendered issue across all areas of our health system. Consent's an interpersonal issue between a woman and her health practitioner. It's also a structural issue in terms of how our under-resourced health systems perpetuate cost-cutting mechanisms that compromise our quality and safety of care. Improving the quality of our consent-seeking mechanisms, including the right to give and withdraw consent, is about more than a form. It requires reshaping these broader health systems with a gender lens. Investing in consent is about health communications expertise, developing content for a variety of audiences in various formats. It's about improving our pre-service training and in-service training of the health workforce. It's about increasing diversity within our health workforce and our health leadership so that our health system leadership is representative of communities throughout Australia. It's about more women and more women of intersectional backgrounds leading health and hospital services, developing health policy, directing clinical trials, writing clinical guidelines, and designing health tech.
So this is the RANS-COG guidelines on gaining informed consent. They state, obtaining consent is an interactive process, not a one-off event. It is a process of shared decision-making where the doctor helps the patient understand their medical condition and the options for treating or not treating that condition. It is more than signing forms and completing paperwork. As you'll see on the next slide, unfortunately, these guidelines are not a requirement for doctors in training with RANS-COG. So here is RANS-COG's workplace-based assessment criteria for conducting a D&C. And as you can see in the top column, where it's for consent and or explanation, the level expected is that they would gain permission and not explain why the procedure is being performed. And the above level expected is that they gain permission and explain why the procedure is being performed. But unfortunately, they do not actually state anything about informed consent in this.
I understand there's been legislation introduced in the UK which has ramifications for informed consent. Mr. Adrian Lower, can you tell us a bit about that?
The Montgomery case is not legislation as such. It was a judgment in 2015 in which a woman called Montgomery, Mrs. Montgomery, sued Lanarkshire Health Board, who were responsible for her delivering her baby, her care during the delivery of her baby. And she was of relatively small stature and had gestational diabetes and a large baby. And in the consent process, she was told that a vaginal delivery probably would be safe. And in fact, obviously it wasn't. The baby had something called shoulder dystocia. It got stuck in the birth canal and suffered severe cerebral palsy as a result. And Mrs. Montgomery maintained that had she been aware of this risk, which was small, less than 1%, which up until now had been considered to be the level of risk at which people should be informed, then she would have asked for a caesarean section. And the judgment felt that she hadn't been adequately informed of the risks and hadn't been given the opportunity to request the caesarean section, which would have avoided the risk of damage to her baby. And so this is an important judgment, and it marks, if you like, the transition between a medical-led paternalistic model of healthcare where the doctor knows best, so that now we're obliged to inform our patients of all of the potential risks, not just those that we consider to be clinically significant, or in our experience and our judgment to be significant. It's up to the patient to decide what she thinks is a satisfactory level of risk, or what she would regard as unsatisfactory and unsuitable, and what she would want to avoid. And this, of course, applies to Asherman syndrome, where the risk of damage is held to be rather low, not as low as many of my colleagues think, but it's held to be rather low. But the fact that there is a risk of it there, then you should be informed about it, and you should be able to make choices to avoid procedures which may increase that risk, although that's a complex issue, perhaps, which we'll come back to later on. But just to highlight where Montgomery sits in terms of legal judgments in medical legal cases in the UK, prior to 2015, the main test was a test in a judgment called Bolam. Bolam claims, or held, that if there is a substantial body of appropriately trained doctors who would support a decision made by an individual, then that is thought to be care of an acceptable standard. So if you're doing something, you can find enough people who would do the same thing, in other words, at postpartum D&C, and there's enough doctors who say, well, I would have done the same thing, then that is defence. But the issue of consent is, would you have warned the woman that there may be a risk of her developing adhesions, is where the new judgment comes in. So it's not legislation as such, but it's an important milestone case, and it's had an impact on the way that consent is given, and we're now much more careful in terms of listing the potential problems which could occur, the things which could go wrong, and making sure that people understand and sign a consent form that's appropriate to explain that level of understanding when you're asking somebody to make a decision. You can't always do that. Sometimes we're obliged to do things in a hurry, and For instance, a caesarean section for fetal distress is very difficult to go through all the potential risks. It takes a long time to do that consent, and in the meantime, the baby may die. So there are extenuating circumstances where you can't always do that. But I don't want to get into the details of cases and so on, but I think that's just to explain where Montgomery sits and the impact. I don't know anything about the legal system in Australia and whether the judgments in the UK are transferable to the United Kingdom, but I'm sure that it's something which will be tested in due course.
In the United Kingdom, as a result of the Montgomery ruling which we referred to earlier, the Royal College of Obstetricians and Gynaecologists, so really the British equivalent to RANZCOG, introduced these guidelines for discussing risk with patients. Mr. Adrian Lower, do you have any comments?
Of course, not everybody wants to take responsibility for the risks that have been explained to them, and some patients will say, look, you please decide for me, doctor, because you know the circumstances, but there are others who would have a strong feeling that they want to do something one way or another. One of the ways that this can be achieved is by explaining to people what the level of risk is in terms that they can understand. So, for instance, something which is said to be very common, occurs about 1 in 10 times, and you would know somebody in your family who's got that condition. Going down to something which is rare, which would be about 1 in 1,000 to 1 in 10,000. So that would be, you would know somebody in a small town would have that condition. And less than 1 in 10,000, it would be one person in a reasonably large town of 10,000 inhabitants who would have that condition. So that gives you some kind of an understanding of risk and the likelihood in terms that people can understand.